Thanks everyone for coming. Super excited to see that we've got both North American and international representation. That's really cool. What we have, I think, is a really interesting topic today from an expert in the field, and really a topic that is sort of like obvious in some ways, and then gets really ambiguous in others when we talk about posterior chain and hamstring recovery, and really trying to specify some of the interventions we have and some of the metrics and proxies we have for such a nebulous injury. So with us today, Dr. Vien Vu is a sports physical therapist in the Division I collegiate setting. And he also has his own business where he consults athletes and PTs for return to sport cases individually. He's also an associate faculty at Tufts University Doctorate of Physical Therapy program, and guest lectures at the University of North Carolina, Chapel Hill, and Ohio University Sports Physical Therapy elective courses. So with that, I will hand it over. Certainly just some housekeeping stuff. Everyone, please feel free to ask questions in the chat. We'll save questions afterwards. But if you have anything urgent, I'll sort of keep in mind and try to tag it in the chat as well.
All right. Good morning, everyone. Good morning, at least in the West Coast of the United States. Thanks, everyone, for joining. I know everyone's super busy. It's never a convenient time to hop on a webinar. So really appreciate everyone for being here. So today we're going to talk about maximizing recovery and targeted solutions for their hamstrings. I'm going to talk about what I do. It doesn't necessarily mean it's the right way. I definitely feel it's evidence-based, but what I'm hoping to generate here is more to curate discussion around certain articles and evidence. And hopefully at the end, everyone can talk about what they do and challenges they've come. And hopefully as a group, we can come up with solutions for everyone. So Alex kind of told you guys a lot about me. So I work in Division I setting at this point. I also do a lot of lectures for PT students in sports electives, so get them interested in that. And then I'm also volunteering as a Power 5 representative for the NATA for collegiate standards of care, which just helps make sure that PTs in that setting are practicing consistently, and we kind of have the same resources to make sure everything's fair game. I'm also membership services chair. Sorry about my epic, always pops up. I know you guys are like, oh God, charting. All right, but aside from that, I'm a membership services chair for the APTA, Academy of Leadership Innovation, where we talk about stuff like this. How do we integrate technology, and how do we take our rehab to the next level? Some disclosures: I am a product evaluator for a lot of different product and tech companies, and then I'm also consultant for a lot of companies as well. And then my last disclosure is that I do teach a course on technology, so I am inherently biased to using technology. But overall, right up front, let's just talk about what we're going to go over today. So the main things we're going to talk about is that it is definitely important to use objective measures, and that's what clinical practice guidelines preach. We also want to think beyond just generalized return and run programs, right? Like instead of just like walk the straight, or sorry, run the straight, walk the curve. Like we want to think about how we can get athletes integrated faster. And then lastly, we want to talk about not just us, like we can't do it alone. We have so much good supporting staff in our communities and on our sports teams that we want to utilize them to get athletes back as fast as possible. So the premises of this talk is, I think we all know Carl. This is Carl the kangaroo. And Carl is a soccer player and was sprinting at max speed. And then Carl gets hurt. We get an MRI. And it says that Carl has a full thickness tear of biceps femoris long head tendon at the myotendinous junction with a gap measuring approximately 4.5 centimeters and surrounding ill-defined intramuscular edema. So pretty severe hamstring injury. At this point, we talk with our physician colleagues and the surgeons, and they say, we are not going to operate on this athlete. So what do we do? So we've all had these issues. And at this point, we have to decide, well, how do we get them back, and how do we get safely, and how do we not get sued? That's also another topic, definitely in this landscape of pro and college sports, right? So can we rely on imaging, and can we rely on ourselves? Honestly, probably not. So you can see here that this study looked at clinician versus imaging on diagnosis of grading of hamstring injuries. And you can see that it's all over the place. I think with clinicians, we think things are more severe than usual, but they seem to be not based on this evidence. But more than anything, the reason why is like, okay, which one's right, which one's wrong? We don't have an answer for that, because even on MRI, 21% of injuries had no sense of injury at all on MRI, yet we thought they had a severe or moderate grade there. So that's something to be mindful of. How about like the different systems? So this is modified patron severity grade being on MRI and this is looking at the y-axis is days to return to sport. So how well does it predict that? Well, what we find is there's correlation between the grading, but if you guys look at the lines, you can see that there's a ton of overlap. So sometimes your 0 grade actually takes longer than the average first grade there. And then grade 2, grade 3, there's a lot of overlap. So there is a definite correlation. We can use this research to kind of predict and estimate timing, but overall, it's not the best. And you've likely just got a poll, and it's a good way to think. Do we need to rethink the way we identify hamstring injuries, right? Like, so we have these patterns of diagnosis, but we need to rethink them overall. And how about other imaging modalities or methods?
Vien, can I ask you a question on that?
Yeah.
So as we think about this stuff, is part of the reason that we are sort of slanted to maybe overdiagnose some of the severity, partially because we're looking at these things a little bit more acutely, right? People come in, even if it's acute on chronic injury, they're coming in with the acute state of it. Is part of it, how we diagnose and treat, but also when we diagnose and when we sort of close the sort of loop on, okay, this is what I believe this injury is.
Yeah, 100%. In the US, we have colleagues named athletic trainers. So they're kind of like the first to cover sports and driven injury. I think this is where they're going to be a little bit better than traditional PTs. I think by physios who do not work on the sideline, they don't get access to assessments like this. So by the time we see them, we kind of grade them when things have calmed down. But I think it's interesting with athletic trainers. They see them acutely. They can see how much someone's in pain, but they can see it calm down. So they're going to have a better picture of like, okay, like what are we going to grade this? I think as physios, we might get scared with acute assessments of hamstring injuries. So if someone's in pain, we're going to just jump to like the highest severity there, is my opinion on that. But next is, so there's more different types. So these 3 here are different types of gradings using MRI imaging. And basically there seems to be no predictive value of it. Even when you add imaging to your clinical assessment, it seems to be very little addition to like how your return to sports timeline is going to be, prediction and prognosis on that. There's a new kind of, well, I'll say new to me at least, area of imaging called radiomics. And basically that's using these mathematical equations to analyze the different parts of the images to tell you if something's going to, if someone's going to return to sports longer. That's promising. There's been a pilot study done on it, but overall it hasn't been consistently shown in the evidence that that's a thing yet. But I think as it's more popular and as our computer processing powers have more ability, I think that's going to become more well studied in the literature as far as it. So is imaging useless? Well, kind of, right? So we all know that image can also help us with location. Sometimes palpation just isn't the best. Palpation changes so different. To Alex's point, palpation is super tender and really big area and all over the place on the first day, but even within the second day, it can shrink and completely be in a different area. And that's where imaging helps, although it's not as consistent as what our prior knowledge of it goes. But looking at some studies and even the clinical practice guideline, it seems to be that, injury location, it's kind of wishy-washy overall on whether it's going to predict return to sports. The overall consensus right now, though, amongst professionals is that the closer it is onto the tendon and attachment of the ischial tuberosity, it's going to take a longer time there. How about cross-sectional area? So it can tell us like how much of the muscle is involved. But overall, so far that shows that that amount of damage that's influencing the muscle is going to it's going to correlate with return to sports times. And then finally, just like with location, the actually specific muscle is kind of wishy-washy on the evidence too. So is it to the semitendinosus? Is it to the semimembranosus? Is it to the biceps femorals? All that, as far as where the injury occurs, it's kind of both sides. Some studies show that it's going to help predict timelines, whereas other studies show it is not. So does imaging help? Still wishy-washy with that, right? So we could see here that 6 months after return to sports, we could see at the bottom in the blue numbers that even on the injured and uninjured side, we could look at peak torque, work, angle of peak torque. All those actually improve after 6 months of someone returning back to sport. But we could see that on imaging, everything still looks pretty bad. There's still more atrophy. So we won't say atrophy, but we'll say things such as atrophy and scar tissue that can influence the overall total muscle volume. So those are decreased, whereas our physical, functional, and dynamic traits are increased. So basically, it's not the best to use just imaging, and it's not the best to just use clinical. We have to figure out a way to match them both. And I think the best way to do that is with clinical, but also using objective measures to do that. So what is the evidence? What is evidence-based care for acute hamstring injuries? I think the easiest way to answer this is not to say what like I do. I'll tell you what I do inconsistent with these guidelines, but I think the best way to look at it is simply looking at our hamstring strain clinical practice guidelines. So this is basically, if you guys are unaware of this, this is basically what physical therapists put together. Sometimes athletic trainers and physicians are on this too, but it's in the physical therapy journal. But basically they scour all the research in this area and they talk about best practice for each area and they grade them. After they're done grading them, they give them grade A through F. And what you can see here that A grade means clinicians must or should perform or not perform a test. And then B is moderate evidence, and that is clinicians should perform. And then everything below that is pretty much clinicians may or may not do it. But overall, we want to follow the A and B grade, right? So in the A and B grade of this article, it definitely suggests for the A grade that we quantify knee flexor strength with a dynamometer. Whether that's isokinetic or a handheld dynamometer, they said each one is appropriate as long as it's being objectively measured. The next one they do is look at assessing the hamstring length and the 90-degree hip flexion position there. So not just like a straight leg raise, but they also recommend that position. And then lastly, for the B-level evidence, which is still should clinicians do, is being mindful of history of injury. So if it's the first time, we can kind of factor in. If they have multiple injuries, that's going to affect our timelines and push a little bit further. We also want to make sure that we're doing an impairment-based progression and we're not just saying, hey, you look good, go out there. We're actually going to have like a checklist of some sort that we're going to make sure is accounted for. And then we're also going to factor in strength, walking, pain level, and areas of tenderness in the diagnosis of it, making sure we rule out more of like lumbar referral pain or any of the differential diagnoses listed on there. And then easiest of all is taking a patient-reported outcome measure. And what's recommended is the FASH. And that's specific to high-level hamstring injuries. So it's better than like the LEFS there.
And Vien, one other thing I think to comment on there is, obviously, you know, the poll will sort of show us, most people here are into the idea of using technology as a proxy for progression. But one of the things I think that you touched on, you know, all of the other kind of qualitative factors that the patient talks about, the things that we are now currently trying to get some of our data models to try and quantify, like history of injury, like impairment-based progressions, all of those kind of things in our heads as we process these things, they should be as black and white as we can about what these things mean, right? What does a previous hamstring injury mean? Obviously predisposes to future injury, but how long ago was it, right? And start to develop as we practice sort of timelines of when we sort of take things into account more or less. So it's not just a picture that we paint that we all talk about having a subjective idea of it, but what does that actually mean? The same way we talk about, you know, limb symmetry index. So taking some of these qualitative measures and trying to apply them quantitatively as well.
Yeah, I love that you mentioned that, because obviously this talk is mainly on like objective measures of like mainly force, right? But there's so much more that encompasses it. I think a lot of nowadays, a lot of colleagues I talk to, when they build up policies for their organization of like, okay, let's say this incoming athlete is joining us. One thing they always put is if the injury was within a certain time, or if there's a history of a certain injury. So it's not just, you know, does this person pass the test, but there's this whole clinical picture to it. This is just to enhance that picture and for us to actually have hard facts of, you know, when we give an athlete and say, hey, we need you to do this, it's to build confidence. And it's going to give us confidence to either hold the athlete back or have an athlete move faster. So overall, I think if you didn't have tech, you would be within one standard deviation of like general timelines you would turn to run. But I know personally I would sleep a lot better knowing that we went through everything to test. One thing I build confidence with my athletes here is I tell them, unfortunately, and this is within the research too, that we test athletes more here than 90% of anywhere else. And I think for that reason that they should feel confident in coming back, and that whatever happens on the field, they did everything they could to prepare. And the other parts, if they do get re-injured, is just the nature of sports. But this is all to support it. But there's a whole picture to be involved with it as well. So next, I'll talk about each of these in general now. So for A-level evidence, just talk about quantifying knee flexor strength with dynamometers. It's called a make test or a break test with a handheld. The make test basically means it's fixed to an object and they're just going to push into it as hard as they can. So this study showed that it is reliable between and within the same rater. One thing is that if you could see here in picture A, the two participants measuring this reliability were two white males that have the same build, right? So they do comment to that in their discussion that it is reliable, but in other studies looking at dynamometers, they did show that sex and BMI is a factor in reliability. So just be mindful of that. I think the best method you can do it is probably going to be in that A position where it's fixed against a table and it leaves kind of the practitioner out of it. This is the way I like doing it. This is called a break test. So the person is going to stand, lay prone, and then I'm going to go and take their leg and I'm going to go ahead and pull it down. So I get their peak force throughout the whole movement. So there's a little bit of eccentric component there. And a lot of people say, well, aren't you testing your strength and not their strength? I promise you, no matter what, you should be able to defeat this person's strength. So it is testing their strength at the peak of it. So yes, you will move their foot down, but it will only record their strength at the strongest point. And in this study from the Aspetar group, which is a pretty respected group, you can see that it's also reliable between the same people. Or sorry, between different people, and then also within the same person as well. The reason I like that better with eccentric testing is you could see here that, so basically the y-axis is peak torque, meters to kilogram, so it's normalized. And you can see here that this is concentric testing on isokinetics, and this is eccentric testing on isokinetics. And 60 just means the speed, so this was at a slower speed, concentric, eccentric, and then 300 means at a faster speed. And you can see here that the concentric speeds, there's actually minimal differences between the injured side and the uninjured side. However, when you test eccentrically, the differences aren't as much, but you can see that an actual deficit is observed there. That's why I like looking at eccentric a bit more. In addition to that, is why I like doing the break test is because I can pull it really fast. And I think speed matters too. And this study kind of confirmed it. So again, this is more on a isokinetics machine, but you can see here that at 60 degrees per second across different angles, that the injured side was injured at kind of like the bottom ranges, that outer end people call, but overall no major differences there. But at higher speeds, you can see these deficits grow everywhere across different angles there. So not only do I like testing a break test with eccentrics, but also at a higher speed. So I'm going to show you guys how I do it. One difference from the Aspetar group is that I actually like having a belt strapped here because I think it avoids compensation. And I'm probably not pulling them as at 300 degrees per second, but I'm trying to pull them as fast as I can here. So here, I'm just going to grab the K push. This person's prone. And I told them, fight me as best they can. I like having a towel there too, just because sometimes you get like that patellar bluntment test unintentionally and it kind of irritates them. So I just have it there. So I'll pull it down and then it will just record the reps for me. So yes, would you do this right away? No, right? I'd probably do like a make test in this position just to get them comfortable with it, just to see if they're comfortable producing force. But for their final test, I'll like to do this test here. And then what you get from that is limb symmetry index. So you can see not only absolute pounds of side-to-side force, but the differences from each side as well.
And Vien, are you cueing them to say, look, I'm going to pull you sort of, you've got to resist me hard as fast as you can? Or what kind of conversation are you having?
Yeah.
Because obviously everybody's speed is going to be a little different. Everybody's strength is going to be a little different, but as long as you stand it to yourself, what's the cueing?
Yeah, I mean, maybe some people in the chat, who here in the chat, just say break if you've ever done a break test before. Because I feel like most people who do a break test end up kind of knowing what speed and how to keep it consistently. So it does take some reps to get used to it, but I feel like my speed is pretty consistent. Cueing is so important. So I tell them, hey, when I go, I need you to hold on as hard and fast as possible as you can, but basically don't let me defeat you. And usually I always win. Notice the table's super low. I'm not letting them win. I'm using my leverage. But the instruction is just like, do not let me win at all costs. And that's what they'll do. Another thing you'll see that's going to come up with test procedure is this athlete's arms. So a lot of people say like, can I hold on to this table? If you're only looking at symmetry as your criteria, then I say as long as you hold it for both sides, it's fine. Or as long as you don't hold it for both sides, it's fine, is the main thing I care about. So regarding setup, a lot of people ask it is, and I tell them, if you're measuring symmetry, as long as you're testing it the same way both sides, you're good there. All right, so the next one, this one is also a popular test that a lot of people use. So this one is supine 9090. This is called like the outer range testing with Aspetar. But basically, this person it's gonna be a make test. You're holding the dynamometer kind of right there, and then make sure their foot is not resting on your shoulder because that's gonna affect force. So it's just levitating off, and they're gonna push into that dynamometer as best as possible. Notice my hand position. I'm gonna try to get my forearms as parallel as possible, just so it's not a lot of work on me. And then there's a belt strapped here so their hip doesn't come up, but they're gonna push as hard as they can there. So the reason that this one has become more popularized is if you could see on this study. So this study looked at the variance explained, which is basically mean this like how much do these tests attribute to someone's ability to progress back to running for these statistics right here. And you could see that this test is actually at the top. So it attributes to like 34% of the ability to assume someone's ready to run or their ability to get to that point. We'll go over all these other ones in a second, but this is why it's more popularized. They didn't look at the break test for this. They did look at the make test, but they had insufficient data to report the variance. Based on where the strength tests are, I would assume it's probably going to be kind of like right here as far as looking at the, if you guys want to read this study, it's a great study. But based on their other data, I'd say it lies right here. So I still feel confident this is a good test to predict when someone's ready to run. The other question people have is like, can you look at Nordics? I think a lot of people use Nordics. I think Nordics are great in some ways. I think it is a good way to test a lot of people at once. I think it's a great like baseline, right? So like, so think about like baseline. Okay, if this is your baseline, you should meet this. So let's say they pass all their tests. I still want them testing individually on the way I do it, but I want them to make sure that they can also reach the baseline on this too. So it's an extra data point, but there's some nuances with the Nordics. So this is just 4 athletes that we tested with a Nordic hamstring test in addition to my test method. And you can see how different it is with the asymmetry. So you can see that athlete 1, the asymmetry generally was underestimated. Whereas when you test one leg at a time with the handheld dynamometer in my position, you can see that the asymmetries come out a lot more. And this was literally a day apart from each other. What I think is happening is during a Nordic, it's a motor pattern where you're asking someone to use 2 legs at once. And I think the asymmetries come out when you ask them to use that motor pattern to test 1 leg at once. So that's just my theory on it, but there's some nuances too. And my findings have actually been repeated in research. So this is the Aspetar group, again, looking at Nordic eccentric strength and seeing how they correlate to isokinetic eccentric strength. And you can see here that there's very minimal to no correlation at all. As far as absolute strength, they also found that there's also very little correlation at all on this. So I think the Nordic test is, there's definitely reasons you do it based on your organization. But I definitely think if you're returning someone back to sport or someone's already injured and you're getting them out there, it's important to test 1 leg at a time. Next is to assess hamstring length in 90 degrees hip flexion. So this is that max hamstring flexion active knee extension test. The only modification I do is I like doing it passive. So active, I feel like there's a lot of guarding, which might factor into why this is so useful. for me, I like passive because if you think about during terminal swing of a sprint, like that force is swinging their leg as hard as they can, and they have to really decelerate using their hamstring. So I like to kind of exaggerate and put the control in me to push it as far as they can, and then them have me stop. But basically what they do here is I'll put the K move on their ankle, and then I'll stretch it. You can see on the tablet that it's going to record the angle. And then I'll let them rest. And I'm taking as far as I can until they say no, or I feel like that's as far as I can push. And I like this because if you can see that range of motion on this athlete, I don't think they can get there on their own, even if they were active and pain-free. So I like doing this passively. And then what you'll get with the K move, and this is a customized test, but what you'll get for this is the degrees. You can see here that there's a difference side to side with this athlete. And then now we've gone to B level evidence. So A level evidence is measuring that range of motion and measuring that force. But now we're going to look at all the B level evidence and what we should still do. So the main thing is factoring history of injury. And this study just looked at of those who had injury history, how many of those re-injured. And you can see here there's a clear-cut difference. Those who had a history of injury are 3 times more likely to get injured than those who did not. Pretty simple there. I mean, if you're injured, you're going to get injured again. And we all know that across every injury. Not much to extrapolate there. So factor it in. The next one is impairment-based progression. So this study looked at 2 protocols. So one protocol is not what you see on the slide, but they basically said, let's have these people they injure their hamstring, and then we're going to put them through a generalized rehab protocol. Their clearance test is going to be a Aspling or H test, which we'll show you in the next slide. But basically, once they are non-apprehensive from that test, we're going to put them in a sprinting program, and then we're going to put them back out there. And then the impairment-based group is what you see here. So they had first, in order for them to get to running, they had to pass the regeneration phase. So they had to pass all these tests here. After that, once they passed the running phase, in order to get to the sprinting and cutting phase, this was all soccer players, they had to pass all these tests right here. So this is the Aspling test. So right here is the Aspling test. So this is included. This was just one part of that control group, whereas this is included as just one part of it. But this is how it looks. And if you're a Kinvent user, you could actually scan this barcode. I don't know if you guys are aware of it, but you can actually share your own protocols and tests in Kinvent now. But if you scan this QR code, you can download mine and save it to your app and use it. So you don't have to do this whole setup. But what I'll do is kind of like a more advanced version of it. So I'll attach the K move to their ankle. I'll strap down their hip, and I'm going to tell them to kick their leg as hard and fast as they can. And so the true test for HS and Aspling test is just purely asking about apprehension. So first, during their warm-ups, I ask them about that. But what I like about being objective with this one is you can see here is I'm going to ask them to kick, and they're going to kick multiple times as high and hard as they can. And just like Alex suggested on strength testing, I cue them high and hard. If you don't say those 2 things, it's going to influence your testing. But what you'll get there is this. So I like checking apprehension, but let's say they feel good, right? What you're missing is that they feel good, but there's a huge discrepancy between the max angle on their right side. And then you can see here, there's a discrepancy between the speed on the right side as well. So their right side was going 371 degrees per second, and then their left one was going 485. So that's what I like with this one. But in the end, if you're doing just a general program, aka usual program versus algorithm impairment based, you can see here that there's a 6 times increased chance of re-injury if you do just the usual program. I will say one confounding factor is that this group, they had a very specific tailored program for the impairment based group. So one can argue that it was the testing, and one can argue that it was just a very well-controlled rehab protocol based on the testing. But either way, both of those nuances show that you need to have a systematic way to approach these injuries and tests, and that's going to result in less re-injuries there. And then in a different one, so they didn't look at, this was the Erickson 2017 study. Comment hamstring, if you guys are used to this study, but this is like a goated study forever. But this is just a general review of hamstring injuries that is a generalized program. So they call this like a functional testing algorithm. So if they pass this, then they move on to the next, and you focus rehab on that area. If they did not, then you focus on that part of the area there. So pain modulation. If they didn't pass strength testing, instead of moving on to like fast movements and apprehension, you just work on strength there. So in this study, it was just a review and a kind of like recommendation, but they didn't talk about actually like the differences between following this or not. But this is mentioned in the clinical practice guideline as far as that other study too about like how we can decrease re-injury rate. Finally, for strength, walking, pain level, and areas of tenderness, basically they say that the diagnosis of a hamstring injury has all this. So it was an acute onset, hamstring weakness, painful palpations of the posterior thigh, and painful with walking. So those are all if those are all positive, they have a hamstring injury. Saying that, in my eyes, it is best evidence if once we clear them to run, that these are all negative essentially. So we're simply just taking this and making it negative. Lastly, the clinical practice guideline recommends using a patient-reported outcome measure, but something that'll actually capture this population well, and that's going to be the FASH. So Kinvent just released this. So if you scan this QR code, it'll take you straight to the FASH on their app, and you can track it over time through their app. But basically, this is very specific. So you can see it asks them simple questions of ADLs all the way up to like single leg jumping and Nordics with discomfort. So it has a very high ceiling. And the reason why this is validated, it's also validated in German as well, is because they looked at a few populations. So they looked at seeing if they can predict injury, seeing if who was already injured, and then seeing who was healthy. So what they found is the healthy people who answered this had 97% on here. So great score. The people who were at risk of an injury, who ended up getting hurt, were at baseline were 97. So that shows you that this cannot predict injury. It should be used to tell if someone is recovering from it, but it cannot tell you if someone's going to get injured. And then finally, the reason why you want to do it for someone who's injured is because those who were injured scored 26% versus 97. So huge difference there. So it can definitely discriminate injuries for you and also tell you about how they're healing overall. And so by the time they're done with rehab, I'd want them to get 97% there. And right now, you guys, the reason I like all this is because you guys can see this is probably the most mixed answer about pain. But yeah, right, like how do we know, right? So how do we make this more consistent? Pain is so subjective, and how we view it. Some of us, not only does a patient feel pain differently, but some of us react to pain differently. I'm taking a student right now, and the second he hears an athlete has like mild pain, shuts down their treatment, super conservative, so very afraid. Whereas me, I'm like, hey, like, you know, I take all these measures using this data. Are you comfortable progressing a little bit harder? And they're more likely to try that out. But this is a more of a confirmation that like we should be more objective to help our influence our decision there.
I think also, you know, in talking to our patients, because sometimes it is certainly the therapist, sometimes it is also the patient that is so concerned about pain, especially if it's, you know, in the chronic hamstring sort of case. I think talking about, you know, the relative idea of pain with sort of muscle breakdown and the pain felt with injury, and how those two things, though are probably cousins in a family, are not necessarily the same person or even sort of brothers, right? So you have to get someone, both a younger therapist and also the patient, to understand, you know, sort of what are the things that sort of brought on this pain? How is the muscle, how is the tissue stressed? And what are the other objective metrics? If we're treating pain as a data point, it is just one data point, just like Nordics are one data point, just like an objective, you know, break test is one data point. And so no one of them, you're treating it all as a matrix together. No one of them is really going to stop you or push you through.
Yeah, like pain is exactly the same way. Like I think the biggest argument right now with hamstring injuries, like, do we do it based on pain or do we actually test people out? And yeah, it's your point. It is one part of it. It's the same talk with like classic metaphors, ACLs, right? Some people say time versus criteria based, but to me, time is a criteria. So it's not replacing it. It's just adding other influential factors into it. So I agree 100%. All right, and then lastly, something you can do, it's kind of emerging. I will gladly tell you guys, as much as I teach a course, there is no huge level of evidence for like counter movement jump, but we'll talk about why it might be useful. But this is a counter movement jump. So basically you're going to have the individual stand with their hands on their hip. You can do it freehand. The biggest thing that you want to make sure is it's consistent. One thing I make sure too is like, if you're using these plates across your whole network, make sure that if your performance coach is testing them periodically and then you're testing if they're injured, is that they're doing it the same way. So the worst thing you can do is test them a different way with hands free when all their data is hands on their hip. And that way you can't judge it because it's like comparing apples to oranges that way. So the main thing with this one is just make it consistent. But basically they're going to go into a counter movement and jump as high as they can. And you can see with this video here, hopefully it'll start. Perfect. So the most important part is the weighing phase right here. So if they're moving around, it's going to skew the data. They're going to jump as high as they can. And then I usually do about 3 reps until I clean my data and realize that like how much bad data there is. So I actually do 5 tests now. So basically the more data you have, when you clean it down, you're likely to have more data too that you can use to influence your decision. But right now I'll do ×5. And then what you'll get on Kinvent is you get immediate scores like this, which you can show them with some nice graphics. And then you also get advanced metrics, things that you want to look at. And then you can click through on the tablet, other areas that you want to look at too. So consulting with Kinvent folks, they were able to put on the metrics that matter most to like physical therapists and rehab people, as well as like power at the top. So we put the most important, but then maybe I shouldn't say, but they are going to release something where you can customize these into a little bit more on your printout. But that's what different things you can look at. So there's like over 200 metrics, right? For hamstring purposes, you just have to look at certain phases of the jump. And phases of the jump we'll go over right now too. So this is a picture of a counter movement jump. So the biggest, most important thing is the weighing phase, right? Because all this force is normalized. So the x-axis is time, force is on the y-axis, but you're just gonna get them in the way. And then finally the app will tell you to start having them jump. So at that point, this is the phase, we call this the unweighting phase, where technically there's less force because they kind of start pulling their knees towards their chest there. And then next is the braking phase, where they're still squatting down, but this time they're actually producing force into the force plates. So this is still the counter movement. And then this is propulsion. So they're not off the plates yet, but this is the concentric portion where they're pushing up. And then obviously the flight is when they're just completely off. So force is at 0. And then they finally land. And this is the huge forces there. So you can see the black line is total force. And then the orange line is left. And then the blue line is right. And you can see here a visual kind of indication of asymmetries there. So of the 200 plus metrics and all these fancy graphs, what do we look at? Well, before we get into that, actually this slide's useful, but I'm sure everyone's read this article already, but this is just to look at why we value a vertical jump versus a horizontal jump. But you can see here, horizontal jump, in theory, you look at distance, so it's looking at propulsion. And you can see here that the knee muscles contribute not much to it compared to a vertical jump. So a vertical jump doesn't completely look at it, right? Like technically it doesn't discriminate hip versus ankle, but it just does it more. So a lot of people are switching over to vertical jump distance. With force plates, it's nicer because you get all these metrics. But the way I utilize them and the metrics I look at is basically these 3 right here. Takeoff peak force, which is right here, this blue dot. Takeoff impulse. So this basically right here, this whole phase colored in. Impulse is basically everything under the curve. And then landing impulse. So the reason I look at this is because this study basically looked at people with a 6-month, or sorry, I think it was a 6-month history of hamstring injuries. And what they did was when they tested them on here, they found that the force plates could actually not identify which leg was injured. So these were the metrics right here that they looked at. So again, this was the takeoff portion. So counter movement, you push off, you're looking at that. And then the second part was landing impulse here. And basically that's everything in this phase right here. The force is there. So basically what I tell people is like, my goal of jumping them on a force plate is I'm going to let you out if I can no longer tell. If I give this just a stranger in the street that could read force plates for some reason, maybe it's a random physicist, they should not be able to tell which leg is injured there. It's the way I use force plate. So who gets tested on force plates for me? Literally everyone. I'm going to put them on a counter movement jump. Okay. One thing to factor in those, although there was no differences like symmetry wise, they're 100% equal, right? I do want to point out that the force plates are accurate. It's the movement and landing that's has high variability. So just be aware that this does have a coefficient of variance of like 19 to 20%. So that's to say that I'm gonna like these ones are about 8 to 10% coefficient of variance. So within 10% asymmetry, I'm okay with. For this one, if they're still like if their LSI is only 80% on landing impulse, I'm still gonna be okay with it. If it's 40, then I'm gonna be a little more, hesitant. The main thing you can do is try to, as best you can, I know it's not ideal for everyone, but take a ton of healthy measurements of that individual and compare it to when they were healthy. That's gonna be your best thing. Then just be mindful of the coefficient of variance when you test force plates. And honestly, any technology you use, just be aware of that.
Then one thing on that, how much are you looking at or talking to them about, landing, obviously in this case, right side, initially impact first and then sort of getting over to that left side later. That being a conversation and a visual for them, sort of a teaching moment versus something that you're just looking at impulse where which one goes first doesn't matter quite as much as long as the volume overall is the same.
Yeah, so I kind of have two answers there. So I think that goes to why healthy measurements of that individual is so important, because I want to know how they naturally move. And I don't think we have the evidence right now to say that we can predict injury with force plate measures. So I just want to see how they naturally move. And then when they retest them after injury, I won't cue them for that reason. I just want to see how they naturally move. That way I can compare their old scores to their healthy scores. As far as cueing goes, I also don't like influencing on that. So I just tell them jump as high as possible and land however you want. That's how I check it. I think with like treatment and rehab, you can cue those based on different ones. So at first I'll have like, hey, work on a soft landing and then work towards like more rigid, hard force production landing. But as for the test, I just kind of want to see how they naturally behave out there.
Yeah, and I think it's just, without having background healthy data on the person, I think it's, when you see, let's say this person has a left hamstring injury, where they're really not loading that side, it's difficult, I think, for us to, in general, have the conversation and say, do we want them loading the left? Or maybe this is just the way they are, right? Like, so I think it's just a difficult conversation, but it adds to the data, to the conversation in general, whether or not we sort of divert them towards that left leg or not.
I 100% know what you're talking about now. Okay, yeah. So a lot of people can't take baseline data. This is one way you can kind of finagle this to make a clinical decision. So usually with the reason I like two-leg is because two-leg says if it's like learned disuse, because it's a motor learning issue. And this comes from research of people tested like that were still fresh out of surgery, and they found that with feedback, they could actually be equal weight bearing on force plates, even right after surgery when there was perceived weakness. Single leg is going to be more strength-based. So saying that if it's a motor program thing, what I do is, or pain, right? They could be babying it. So let's say like you didn't test baseline, they're 20% on one side, they're uninjured side, but you don't know the baseline. What I'll say is, hey, I want you to jump and I'm going to give you feedback on here until you land 100%. If they land 100% pain-free, that tells me they can do it if asked. It's just probably they're not used to doing it yet. So if they're painful with it, I'll definitely be like, okay, I actually want this at 100%. Or if they just can't do it ever, like they just don't know how to do it, then I'll also work on that, because a healthy individual should have their natural jump, but should have the full ability to manipulate their movement as they need. So that's the best answer I would give you there. If you don't have baseline info, at that point, test if they have that motor learning ability to do that, and if they have pain when they do that, so it can help rule out, why are they not able to do this kind of deal.
Right. So they may still rely on the other side because it's habit, but they at least have the ability to control what they're doing.
Yeah.
I think the other thing, and you may touch on this from your teaching in general, I think, you touched on the form if there's a strength and conditioning coach involved or there's anybody else involved to make sure everything stays stable. I think physical therapy, medicine in general, or allied health in general has been a little bit slower than than performance coaching to the technology sort of conversation. And so we're catching up a bit, but there's also times where we're not, right, in some of the youth sports. And so for those that do have to deal with those conversations, whether or not we are trying to, I guess, two camps. One is we're trying to prove that we do know what we're talking about with some of these metrics. And the other one is we're trying to educate people on some of the metrics. Any tips that you have on getting through to those populations or to those professionals outside of us?
Yes, I love this question, because this is not a technology question. It is a relationship building question. And that's the biggest thing. Like, a lot of people end up buying technology and then they don't use it. So one thing I like about this is, like, I'm just kind of showing the way I do it. So maybe you guys can try it in this consistent manner. But one thing is, like, a lot of people do not like being told what to do or that they're doing things wrong. And I agree. Like, my biggest thing is, like, shout out to my residency folks, but they loved when I was at residency, people loved me and my co-resident because they're like, man, these guys are loading heavy, and they passed their ACL testing, right? And then we watch our mentors do motor learning, like little balance stuff, like single leg unweighted squats. And so our mentors are like, man, this is really refreshing. But if you take a step back, for 20, I think at the time, 26 years, they were doing that and they still passed their test, right? So it's like, I tell people, I don't care how you get there. I think it's just matters with testing. Saying that, if you're trying to get someone to adapt, like, I think you should definitely, the hardest part is acquiring the funds for this. But once you get it, just do your own research, experiment, work on you, get your process down. And, if someone consults you for it, you could just educate them on things you're looking at, but you don't have to tell them you need to do it this way, you need to do that. I think once you just focus on yourself and they see you get into this routine, like, oh, like, everyone here knows my routine exactly. Vien's going to do this, Vien's going to do that. They're going to come across a very hard situation. Like that case I told you was a real athlete of mine. They're going to cross a grade 3 hamstring injury with maximal retraction, and they're going to say, I think I need some extra help. And I'm going to, hey, Vien, I see you doing this stuff. Like, can you actually do the testing for me and tell me what you think? And then the next conversation, hey, Vien, can you teach me how you do the testing? So I think you definitely need to come in and just worry about yourself and just focus on that. And then once people see that you're not pushing onto them and you're there to help, that'll grow there. And I think you also need to be patient, that this isn't going to be like a 2-week thing. You're not going to bring this technology in and get everyone on it in 2 weeks. You need to be aware that this is going to take 3 months, 6 months, a year for people to finally start adapting it. But you just need to be very consistent and persistent on that. So long story short, to get people to buy in, don't force it on them, and just really believe in what you do and trust that, stay current with the evidence, and then other people will eventually catch on to.
Yeah, I think that's absolutely right. The idea is, a mentor of mine once said, look, just count your patients, right? No matter whether or not you're doing a good job or not, as long as you're taking measurements, you'll figure out how to do it better, as long as you're consistent with yourself. And I think, and certainly I'm going to be a little biased towards Kinvent, but at the same time, I've used all of the same ones that everyone else has with Vault and everything else. But the idea is you want tools that are as flexible as our job is, right? If you're buying force plates just to do hamstring testing, you're buying them for the wrong reasons, right? Just because Vien says to do counter movement jumps, and that's why you're buying for all your hamstring cases because you use too many, that's all you're going to use them for. It's a waste of time and money, right? Many people have tools, start using them and upgrade them because you need to, or get tools and start using them in the ways you do it. My hamstring testing, I actually use a pull dynamometer and a belt around my waist so they can't move me and they can't move a 110-pound female, and we can test the same pro athlete. And so that way, we may test differently, but we all know that we're going to just take objective measures, and the measures are flexible to what you as the professional need, as opposed to an engineer in a lab somewhere saying, this is the test I think you guys should use, right? We're going to be looking at research, and research changes over time, opinions change over time. But as long as you have the flexible tools to then apply to that changing landscape, you have a much better way to, like I said, count your patients and know when you're sticking to your guns, like you said, or, you know what, I think someone's doing it better. Let me use a force plate to assess, power, or, mid-thigh pull or something to that effect. as opposed to the way I've been doing it.
Yeah, it's so different. Like, it's what you said. Only buy things that help you answer the questions you want. And as long as you're consistent with your setup, you're good there. So 100% agree there. So overall, this is my protocol. And you can see here, so this goes down to which test. So I put P because technically I don't do active, I do passive. These are different tools that you can use to measure that. These are the goals I'm looking for. And then, let me hide this. Sorry, guys, I didn't know that was there the whole time. And then you can do the QR codes. And this QR code here puts you to the protocol of all these combined into one, if you want to use that way. Okay. Except for the FASH, because FASH, you might not want to have to run through the whole protocol, so that one's separate. And it's default in the app anyways. All right, so
I think generally, sorry to interrupt you.
Yeah.
I think in general, to be honest, the idea of having a QR code, like I just did on my phone, honestly, but the idea of being able to just take a QR code and just download somebody's protocol is kind of incredible. Again, obviously a plug for Kinvent, but at the same time, like that's pretty unheard of to be able to do it, just sharing it that quickly, right? Vien and I are on a complete different network. I'm on the East Coast, he's on the West Coast. We both use Epic, but that's about the only similarity, right? In the collegiate setting, I'm at the hospital for surgery. There's really no connection between us. And the only way that I can get him or his protocol to share with my colleagues on my login is through this. Or we have to painstakingly exchange emails and go back and forth and say, okay, wait, how do you do it? And then I have to program it into mine. So to be able to do it that quickly and just put it in mine, it's pretty awesome.
Yeah, I wish we could share dot phrases, you know what I mean, on Epic. But yeah,
able to, but it's pretty good.
Yeah, and I will say, so this is my protocol. I know I did the dumb thing and I said Vien's protocol. It's named Vien's protocol. Like the Arnold press. I just hate when people name it like that. But everyone has so different ones. And this one, if people have concerns or questions, I love feedback. I'm totally open to changes. Now they know they can just contact me and they can critique me and I can answer all the questions and you don't get blamed. So it's okay for my name to be there. All right, finally, this one's going to go a little quicker, but sports league integration. So what do you do when they pass their test, right? Generally, you put them on these. There's a lot of, and this is nothing wrong with these ones, but a lot of the programs out there, it's like slow running, right? So let's run for 1 minute, run a lap, or something like that along those lines. Even for ultra distance runners, there's protocols for that. Very, very generalized, but something I had to look at was for other sports, right? So these are all the sports at Stanford. And only 5% of our sports technically run long distance, right? You could argue soccer, but there's some anaerobic parts of their game as well. But for the most part, that only makes up 5%. So we need to look at other sports. And it's important we look at other sports because if you look at this, so this study looked at jogging demands on the hamstring. And this is times the body weight. So you can see that from, kind of like a fast jog to a fast run, it's a 20% increase. Going a little faster, it's 7%. And then from running to sprinting is a 95% in effort or times body weight on your biceps femoris. So sprinting is just different than jogging. So one, it's going to help your progression, but it just calls on like those generalized programs aren't going to be the best ones for you. This is also another study looking at those high speeds, so 80 versus 100% of running. And you can see here that even though it's just a 20% increase in speeds and effort, you can see that for the semimembranosus, it's a 48% increase in newtons per kilogram of your muscle force and a 42% increase for biceps femoris there. So some things you can even do outside of just jogging is if you have a treadmill. So I promise this is slow motion, maybe, but this is going to be an uphill incline, and I'm just going to be sprinting on it. And there's two useful things for this. I think the treadmill is going at 60 miles per hour I had it at. And I think that's 100% incline, but I could be wrong. But what you'll find here is that I like doing this and having them kind of work those high speed joint velocities. Because if you look at, so this is incline, 6% incline versus 9. You can see that knee flexion angle at mid stance is going to be a little bit less there. And there's less forces that way. So it's better absorption. So it's greater at mid stance here. And then also though, you think about like terminal swing, because it's uphill, this is the max extension, knee extension I'm getting because it's uphill. And then overall, the impact forces are way down too. So you do get forces at mid-stance that you can get hamstring injuries at mid-stance. But overall, this is a good solution to just a generalized running one. You could actually get them working through those velocities a little bit faster that way. And then the best part of my job is I work closely with all my coaches. So these are just some of the teams I work with. I work with track, mainly sprints and jumps and throws, field hockey, and then American football. But once I feel they're ready to run, I'd let my coaches take over. We are not going to do slow jogs. We are going to go and set very specific things to make sure the athlete feels like they're back to normal. And I know the most important thing is I test them and I know they're ready for these. And so I feel confident that my coaches are doing a good job and they're ready for what my coaches do. But these are just progressions that the coaches do. So one thing that the football staff like to do is they like to not have the athletes on their own. They like to integrate them where they are. So if it's an uphill sprint workout, they'll have them along with the team, but doing walks. They'll have them do tempo jogs. I say jogs, but it's fairly high speed. And then they'll go a little bit even steeper on the uphill, and they'll finally go to uphill sprints. If it's sleds and sprints, they'll go from marches to switches and skips and bounds to sprints. Change their directions. They'll be integrated with the group, with the team, but they'll have a bit modifications. And then for practice, they'll build up their same volume and speeds from GPS with a emphasis on distance and volume first, and then go into full intensity there. For my track coaches, they all have a warm-up. So I know exactly which warm-ups they do. So they might have a generalized warm-up for someone coming back from injury. They have a meet day warm-up. So we'll progress through these 6 ones to kind of get a gauge of it. But Coach Coop, I know that he's going to work through the warm-up. He's going to do hurdle walkovers, grass strides, and then strides. Once you're done with that, I know he's going to go into sprint-oriented warm-up. So he's going to work on accelerations, getting to certain positions. We're going to do hurdle hops, and then we're going to do 50-meter sprints. And then he'll repeat this whole protocol in spikes. So just by knowing what he does, I feel safe that my testing and rehab prepared him for it and that they can integrate into these quickly rather than those boring like jogging protocols. Similar for Iggy, he's jumps. So again, the warm-ups, and then he'll do double leg support, work on vertical jumps only, and then we'll go into changing angles. So for like crazy broad jumps to handle the landing impacts, they'll do pogos, and then more of like soft landing, and then finding that rigid knee I was talking about where they can transfer force really well. And then once they're done with that, he also has more advanced jump specific ones. So you can see this athlete. Imagine if this athlete had a hamstring injury. So we'll do something slow like that, where the terminal swing and impact is very light. And then we'll go into bigger ones. So he has a little bit of rest for that leg. And then finally, before doing full jumps, we'll bring them into the sand. We have a beautiful sand court that we have access to. And it's a different setting, but we also shorten the distance. And so he'll kind of fully progress there. And then finally, we'll work into full go, where this athlete will do a maximal sprint and get into his triple jump as far as he can. So just understanding how to get athletes there and what our coaches do will make our athletes enjoy their rehab time better. And then it's important because this is what they look like, right? Like imagine coming off a hamstring, their max sprints, max jumps, and then getting to that position. We have to make sure they're prepared there. For throws, they'll do seated throws, half kneeling throws, warm-ups, have a conversation about how they feel about their hamstring. And yes, throwers get hamstring injuries because some of them do conditioning, sprints as conditioning to prepare their anaerobic system. And then they'll just do concentric movements only, progress to plyos, and then finally modifying from stand throws to half turns to full throws. And then lastly, we have field hockey. So you could see these gnarly positions that they put their hamstrings in, but actually they don't get injured from this. They actually don't get injured from field hockey because they're hunched over, so they don't really run full speed. They actually get most injured during sprinting and conditioning. So yes, they get hamstring injuries, but also our coach can get ready for that. So this is Jamie's progression. So Coach Jamie does wall drills, running drills, dribbles, progression, dynamic agility, and then finally she'll use the GPS data. One thing too is because we know the sport does not get into full sprints in game and practices, that you'll see that we actually integrate them in practice before full sprints there. So that's something we do. But all that said, this whole point was to kind of plan backwards. So this is a great article from Lionel, but basically asking the question, right? In order to determine here, we have to start here. So first we determine what are the needs and demands of the sport and what do the coaches need from this athlete. We determine the objective criteria. This is how we develop that protocol. We then say, okay, this is our criteria, but how do we test that, right? So we know they need equal symmetry side to side, but what position or what test are we going to do? What device are we going to use to test them there? And then finally, that helps us with our treatment there. So knowing all that, I'm going to make sure this athlete is really painful right now or is really weak. So we're going to work on just those two things. And then we're going to have and test these things as they go. And then once they meet those things, we're going to move up this ladder because we plan backwards there. And these are examples. And you guys will have the slide deck. If you obviously registered, so we'll hand out the slide deck to you guys. But this is just integration. So what they do in rehab is here. And then what they do in practice for sprinters is here for track. And you can see here that at no point they return a run test, but they're not doing a generalized jogging program for anaerobic sport. For field hockey, again, right? Very specific to the sport and the coaches. Like they are allowed to do stuff and they don't need to work on energy systems or tasks that they're not going to do in their sport. And then lastly, for football. Even for football, which gets through some distance during practices and games, you can see at no point are we going to have them just do a generalized jogging program. There's other ways to test out their comfort, but also get them highly integrated with their practices there. And then the last thing I want to talk about is like, so what do we do once you're healthy? Honestly, monitoring really doesn't have too much research there. So I think it's important to test them once you're injured. But so far, no matter what test you do, no matter what metric you do, it doesn't really show that we can identify who's going to get injured or re-injured after an injury. So I value testing. I still do baseline testing because I like having that baseline of normal. But overall, I'm not going to tell an athlete they're at risk or anything like that. Okay. So in summary, this is my protocol. So from table to standing, this is all the tests I do. In between here is lumbar screening. So you don't want to leave out lumbar screening. It could be a lumbar referral pain. But you want to make sure you get your table test and then you get your standing test. For return to run, these are the things I look at. And these are based off that variance paper we looked over earlier in 2018 from the Aspetar group. But all of these things should have pretty low irritability early on. So this is what I hold them to. And then for force plates, you can see here that I put within baseline, not symmetry, because we talked about the nuances of that, right? But you could download the protocol here if you have Kinvent, and then you could use this protocol, and this is criteria I'm looking for all these tests there. So again, summary, use objective testing. Everything should be different depending on the sport, and then leverage your staff's expertise. You can't do it alone, and it's important you don't do it alone. Utilize your expertise because they probably know a lot more than you in their areas, and help the athlete kind of feel that team feel again. These are my references, and again, we'll send out the handout to you guys. And just a reminder that everything I taught you today was not just me. It was taught from all my colleagues that teach me everything at Stanford. I'm extremely proud of what we do here. I think we're the best in the country at what we do. And this is just a reflection of all of them. And I hope I represented them well. Thank you, everyone.
Awesome. Thank you. Yeah, I think good discussion, good conversation in the chat as well. We're going to cut the discussion a little short unless you guys have some pertinent questions. Feel free to sort of shout them out in the chat. But we'll have snapshots of this. We'll obviously share the slide deck as well. But thank you so much, Vien. Incredibly helpful, very evidence-based, and I think gives us a really good idea of how to treat these athletes.
Thank you guys for joining me. Yeah, extremely grateful that in the middle of the day or evening when you guys can do anything, you guys are joining. But I'm happy to take any questions. Handouts will go out. Unfortunately, I don't think, or the recording will have questions at the end. So if someone wants to view later, you guys can do that. But happy to take immediate questions now. Feedback is always appreciated. I'm always looking for ways to improve as well.
Awesome. Thanks, man. All right. Good seeing everybody. We'll see you at the next one in a few weeks. Thank you.
Thanks, guys.
See you guys.
Bye, friends.